Gonorrhea is a sexually transmitted infection (STI) caused by the bacterium Neisseria gonorrhoeae. Historically known as the clap, it has been documented for centuries, but modern public health concerns stem from its rapid spread and the potential for severe complications when untreated. The infection can affect the genital tract, rectum, pharynx, and eyes, and it can be transmitted through vaginal, anal, or oral sexual contact, as well as from an infected mother to her newborn during delivery. Because many individuals, particularly women, may be asymptomatic, the pathogen can silently propagate through sexual networks, making early detection and treatment critical to preventing long-term sequelae such as infertility, pelvic inflammatory disease (PID), and increased susceptibility to HIV. The causative agent of gonorrhea is Neisseria gonorrhoeae, a gram-negative, oxidase-positive diplococcus that requires enriched media for laboratory culture. Its outer membrane proteins, for example OPA, POR-B, facilitate adhesion to mucosal epithelium, while its lipooligosaccharide, LOS, contributes to immune evasion. Strains have increasingly acquired resistance mechanisms, including penicillinase production, altered penicillin binding proteins, and mutations in the JER-A and PAR-C genes that confer fluoroquinolone resistance. Transmission occurs during unprotected vaginal, anal, or oral intercourse, and vertical transmission can occur during childbirth, potentially causing ophthalmia neonatorum in the infant. After inoculation, N-gonorrhoeae uses type 4 pili and opacity OPA proteins to bind to the mucosal epithelial cells of the urethra, cervix, rectum, or pharynx. The bacterium then invades the superficial layers, triggering a local innate immune response characterized by neutrophil recruitment and production of pro-inflammatory cytokines IL-1 beta, IL-8. The resulting purulent discharge is a mixture of bacteria, neutrophils, and inflammatory exudate. If the infection is not cleared, the organism can disseminate via the bloodstream, leading to disseminated gonococcal infection, DGI, with manifestations such as tenosynovitis, dermatitis, and migratory polyarthritis. The pathogen's ability to vary its surface antigens enables it to evade antibody-mediated clearance, contributing to persistent infection. Globally, the World Health Organization estimates approximately 78 million new gonorrhea cases annually, with the highest incidence in adolescents and young adults aged 15 to 29. In high-income countries, men who have sex with men, MSM, and sex workers bear a disproportionate burden, while in low and middle-income settings, limited access to diagnostics fuels underreporting. The rise of antimicrobial resistant, MR, strains, particularly those resistant to cephalosporins, has prompted a resurgence of gonorrhea in many regions. Surveillance programs, such as the US CDC's Gonococcal Isolate Surveillance Project, GISP, monitor resistance patterns to guide treatment guidelines. Clinical presentation varies by sex and infection site. In men, urethritis typically produces a thick, purulent discharge, and dysuria within 2 to 5 days after exposure. Women often experience a milder watery or mucoid cervical discharge, dysuria, and intermenstrual bleeding, but up to 50% may remain asymptomatic, leading to delayed diagnosis and ascending infection. Pharyngeal gonorrhea presents as a sore throat, while rectal infection can cause tenesmus, bleeding, and anal pain. Approximately 10% of infected men and 50% of infected women are asymptomatic, emphasizing the importance of routine screening in sexually active populations. The current diagnostic gold standard is nucleic acid amplification testing, which detects N-gonorrhoeae DNA or RNA from urine first catch in men, or from vaginal, cervical, rectal, or pharyngeal swabs in women. NAATS offer 95% sensitivity and 99% specificity, and can be performed on a single specimen for both chlamydia and gonorrhea. Gram stain microscopy can reveal intracellular gram-negative diplococci in urethral specimens from men, but its utility is limited in women due to commensal flora. Culture on chocolate agar remains essential for antimicrobial susceptibility testing, especially for tracking emerging resistance. Clinically, gonorrhea is categorized as uncomplicated when the infection remains confined to the mucosal surfaces of the genital, rectal, or pharyngeal tracts. Complicated gonorrhea denotes dissemination beyond these sites, such as disseminated gonococcal infection, DGI, involving joints, skin, or the cardiovascular system, or when the infection causes pelvic inflammatory disease, PID, in women. Some authors further describe infections as primary, secondary, or recurrent. The CDC 2024 guideline recommends a single intramuscular dose of 500 mg ceftriaxone, 250 mg for patients up to 150 kg, combined with a single oral dose of 1 gram azithromycin in cases where chlamydial co-infection has not been excluded. For confirmed cephalosporin-resistant strains, higher ceftriaxone doses up to 1 gram or alternative agents such as spectinomycin, gentamicin plus azithromycin, or emerging oral agents such as gepotidacin. Zoliflodacin may be used under specialist guidance. Test of cure is advised 1 to 2 weeks after therapy for pharyngeal infections or when resistant isolates are identified. All recent sexual partners within the past 60 days should receive empiric treatment, expedited partner therapy, to interrupt transmission cycles. Barrier methods, condoms for penile vaginal or penile anal intercourse, and dental dams for oral genital contact remain the most effective personal protective measure against gonorrhea. Routine screening for sexually active individuals under 30, pregnant women, and high-risk groups, MSM, sex workers, those with multiple partners, enables early detection and treatment. Expedited partner therapy, EPT, facilitates rapid treatment of contacts without a clinic visit. While no vaccine is currently licensed, several subunit and outer membrane protein candidates are in phase 1-2 trials, offering hope for future primary prevention. When appropriately treated, gonorrhea resolves without long-term sequelae in greater than 95% of cases. Untreated infection can progress to pelvic inflammatory disease in women, leading to chronic pelvic pain, tubo-ovarian abscesses, ectopic pregnancy, and infertility. In men, chronic epididymitis may occur, though it is less common. Disseminated infection carries a risk of arthritis, tenosynovitis, and skin lesions, which may become chronic if not promptly managed. Early diagnosis and partner treatment dramatically improve outcomes and reduce community transmission. 1. Antimicrobial resistant surveillance and novel therapeutics. Phase 3 trials of oral agents like zoliflodacin and gepotidacin show promise against multi-drug resistant strains. 2. Point-of-care diagnostics. Nanoparticle-based NAAT platforms and CRISPR-Cas13 systems can deliver results within minutes, potentially enabling same-visit treatment. 3. Vaccine development. Protein-based candidates targeting conserved outer membrane antigens, for example, POR-B. OPK-A are in early clinical evaluation. Adjunctive strategies, such as bacteriophage therapy and monoclonal antibodies, are also being explored as future options to circumvent rising antibiotic resistance.